This is Caroline.
Mary Tess.
Neil.
And this is Laura. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med Surg nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Our topic today is how to manage post-op handoff and care. But before we get started, let's see what's new with everyone. Caroline, why don't you start?
Hi, everyone. Hope everyone's doing well. So as I turned the calendar recently, it hit me that we've been back in Georgia for 6 months. We moved into our home in October, and it's not a brand new home. And that might sound really odd to people, but my whole adult life, I've always lived in a brand new home. So this was a home and someone I'd loved and cherished for 20 years. But after 20 years, there are things that need to be done. Having ripped out the kitchen and put in new floors, our latest project is now to have replacement windows put through every window in the house. So that's the latest project. Very interested in watching sales presentations from window salesmen. I've learned more about BTUs and indirect and direct heat than perhaps I've never wanted to know. My daughter as well. She's been married now almost a year. It's just amazing how time flies. If you've been a regular listener, you will no doubt heard all about the wedding plans, and now we're a year down the road. They're still enjoying each other, let's just say that, and traveling around. I asked Jennifer about a weekend because she come see her grandma. She's like, we'll be in Europe, Mom. We told you about this, Mom. But don't you hate those conversations? So they're celebrating their first wedding anniversary in Brussels, Amsterdam, and Paris for 10 days. How nice to be young and kid-free, you know? So she's doing very well, and we continue to be very happy for them as well. Mary Tess, what's going on with you?
Well, I will share. I know last episode, if you remember, I shared about my daughter doing crochet, arts and crafts. And so it sparked a little interest with the other kids. My other daughter, we used to do arts and craft shows selling custom-made jewelry. And so when that happened, she started opening her box again. It's not October. We usually do that during the fall festival, just join arts and craft show. She opened it and started doing her own jewelry again. And so it sparked my interest. And I was like, can I try? And I know Laura mentioned in our previous episodes doing arts and crafts, right? And so I was like, you know what? Let me try. I found out I can't do jewelry. So I can actually do it. It's not the best, but I love doing it. There was one time I was already 3 a.m. and I was like, well, I need to go to work and this is my waking hours, but I don't feel tired. And so I think that's a great discovery. So sharing that I can be artsy. Neil, what's new with you?
Mary Tess, I love that, though. I love just creating things because you just zone out. It's so different from what we do. And Caroline, you mentioned your house. I do ceiling fans, I do floors, I don't do windows, okay? Just FYI, if you need me to visit and do some ceiling fans, you do some flooring, it's almost that arts and crafts thing. So actually, I haven't done any house improvement lately. I have actually, I think I might have mentioned in one of our last episodes about trying to eat healthier, and we were talking about our habits and healthy habits. I have been seeing my personal trainer. His name is Duff, like the beer. So that's been a good 2 or 3 week consistent labor of love I've been doing for myself. And I do feel so much better hitting the gym and all the benefits of serotonin, dopamine, cardiovascular health, besides some strength training. So that's been great. On a little sad note, I took my dogs, which are my life, of course, to the vet to get all their checkups and shots. And my boy Blue, he's my 7-8-year-old little pit bull mix. He has some kind of little sty on his eye. Nothing major. He's going to get operated on March 15th. So, of course, that brings a little tear to my eye because, of course, with animals, we worry about them more than humans since they can't tell us what's going on.
Good luck. Good luck.
Yeah. I had a really great Valentine's Day date with my daughter, who is going to be my forever Valentine. She goes to Appalachian State. She's a sophomore, a business major with a minor in Chinese and military science. Because she's in the Army National Guard as 42 Alpha, which is human resources, which goes with her business degree, So she's going to do her officer work after. So she signed on to be full-time, I guess you could say, in the Army after school. So she'll be an officer coming out from college. I'm just excited and proud of her. We had a great little Valentine's Day get together, just daddy-daughter time, which is priceless.
That's wonderful. Wow.
Oh, yeah.
I'm so proud of her. That's great.
Laura, what's going on with you?
Oh, wow. Everybody has such great stories, and you reminded me of things that I needed to do. Maritas, you were saying that it's all about how much fun you have when you're doing crafts. That is exactly what it's all about. My crafts are nothing to write home about, but they give me joy. Just sitting around and playing and seeing how much better I can get the more I practice. I actually sat down and watercolored a little picture yesterday, and that was fun. Caroline, your story reminded me to share with you guys that my husband and we celebrated our 10-year wedding anniversary back in November, and we are planning a Belgian trip. We're going to Belgium at the end of April. So we're going to be spending some time in Bruges and Ghent and Brussels and a little time over in Amsterdam. It's going to be kind of quick, but it's something we've been planning for a while. So we are excited about that.
Well, that's wonderful. So 2 things to bring back from Belgium: chocolate and lace. Belgian lace. Yeah.
Those are on my list, along with some beer. We're going to ship some beer back.
Oh, yeah, of course.
As well.
How could I have forgotten the beer? Enjoy. That sounds fun.
Oh, yes, we will. We're excited about that. All right. So why don't we move on to our topic? Today's topic is one that I suggested, which is how to manage post-op handoff and care. And since it's my topic, I thought I'd start with a little background as to why I chose this topic. We do a lot of different episodes on this podcast, but we sometimes want to focus on the clinical aspect of it. And so when I think about problem areas on the clinical side, this is one that I think is pretty important because all of our patients are in the hospital for one reason or another. And 9 times out of 10, they are going to have some kind of procedure. So whether they are going down for an x-ray or they're going down for a surgery, we have to do our part to make sure that they are ready to go down for those procedures. So I always like to be sure that new nurses are aware of the different things that have to happen for these patients, specifically with surgical patients. Does everybody understand how important a consent is? Nurses are not responsible for getting consent, but we do have to check to make sure that it has been completed. If patients don't understand or you're hesitant about whether they truly know what's going on, then we have to make some phone calls to get those questions answered. The other thing is preparing them to go down for the procedure. It's important that we understand what the procedure is and what's required. A lot of times we have to make sure that our patients have working IVs. We have to make sure that they are fully undressed. I know I used to work near the PACU area, and I would hear stories when the team would come out of surgery and the patient was not undressed. And it's very difficult to undress a patient after they've already been sedated. So it's important that we are taking a peek under that gown and making sure that our patients did truly remove everything, including things like piercings. So we can't be afraid, we can't be shy to ask about things like piercings that are not outwardly visible to us. The other thing, it's also equally important to be prepared when these patients come back from surgery. How would you feel if you came back from surgery and your room was a mess, your bed was not made? I always think about just going that extra mile, and before your patient comes back, let's have some fresh sheets on the bed. Let's have the bed open and ready to welcome the patient back. Not only will your patient appreciate that, but your PACU nurse will appreciate that as well. Do your best to try to be in the room when your patient comes back. They're going to want to see you. If they see your face and you have taken care of them before they went down, you're going to be a source of comfort for them when they come back. So try to make a point of being at the bedside when the patient comes back to you. Caroline, do you have any other experiences to share?
Oh, Laura, you have said so many things that I can expand on. Oh my goodness. From the pre-operative preparation, everything you said, I agree with wholeheartedly. I think it's so important to emphasize, especially to new nurses, that we are not licensed independent practitioners. We are there to witness a signature and make sure that consent gets on the chart, and that is it. We are not at liberty to explain, to answer questions. That was not within the scope and standard of a medical surgical nurse.
Exactly.
The underwear scenario, I mean, there is nothing more irritating than being in pre-op and having to disrobe someone, and then where do you put the stuff? Where does it go? Who's going to take care of it? And then it gets lost, and then you've got issues.
Yes, I forgot about glasses and dentures and things like that. Exactly.
Dentures, and hearing aids, which patients are very dependent on, and we need to recognize that. The safest thing to do is take them off before the patient leaves the room, so you know where they are. And then the room, oh my gosh, you just hit a nerve. I cannot stand it when patients come back to the room and it looks like a bomb has gone off in there. This is your opportunity to change the bed at the very least. Clean sheets, people. Clean sheets, so important. Pull the trash, tidy up the room, keep that room warm. A lot of housekeepers in our facility are told to think about energy and saving energy, so turn off the lights, turn down the temperature. Patients are freezing cold when they come out of the OR. They come back from PACU with all of these blankets on them, and they need to come back into a warm room. So before we even get into vital signs and looking at wounds and measuring Foley's, think about the physical arena. Think about the patient's comfort from all of the nice things that make someone feel welcome back. I love the way you said that. Welcome back into the room and in a nice, warm, clean, welcoming environment. Then we move into the vital signs and all that good stuff. What does everyone else think about that?
I think it's very exciting because there's a lot of stories that we can tell. Not sure if you guys use a pre-op checklist, but you know how those pre-op checklist works, right? It depends on the preference of the physician, or depends on the unit, whoever is receiving the patient, whoever is the nurse receiving the patient, and all those. But you hit a lot of high points, Laura and Caroline, the things that we need to prepare. But, you know, one of the things that I really like looking into is that the antibiotics. Some of the nurses would administer the antibiotics while in the unit. Why would you do that? Why would you do that? Because they see it in their MAR that it needs to be given 30 minutes before they cut the patient. And so I think that's really very important, not just really following the protocols, but getting that into your critical thinking. What are the things that is really needed by our patients? The high points, physical aspect too, when they come to the unit, the medications that needs to be restarted right after the surgery. I know I can go on and on.
That's a headache.
Right? It's a big headache, Laura. You're right. Because the medications that are not started because this patient was on an NPO for some time, the diet, the patient was an NPO pre-op and then post-op, still an NPO after 48 hours. Like, what?
And if they're diabetic, that's another thing you have to remember to check into.
Correct. Yeah. A lot of things that I wanted to share, but I think it all boils down to focusing on what the patient needs at the time that you receive them, because every patient does have different needs after a surgery.
Great point, Marites. I will definitely say in all of my time in nursing, some of the most frustrating moments is that consent and the doctor just breezing through with the patient, and they'll ask you 101 questions. It's like, that's way beyond my scope of practice. And they should have the doctors with the nurse there doing it together, like all three. What? I'm going to call them doctors out. I love them.
Oh, yeah, that started.
And like you say, Marites,
Freaking out here.
I'll say this, the hard part about floating nowadays is I'm in 4 different hospitals on multiple floors of your med surg, your renal, your ortho. And it's true though, if you're on one unit, you know, Dr. Bob likes to do this, this, and this before surgery. And Dr. Tom likes this, this, and this. I have friends that are OR nurses and they're like, oh yeah, he likes specific instruments in this order, his table's set this way. And even coming out, you almost know exactly what certain doctors will prescribe. I will say this, I love working for Moses Cone. Our post-op patients will get the Tylenol every 6 hours, Neurontin and Robaxin, muscle relaxer, to move away from the opiates and the narcotics. And I love that because we, I think, created such a crisis not too long ago with becoming so dependent on meds like that. And these are a lot less sedating, especially for, I feel like, our older folks. But yes, I wish there was a consent situation we can deal with. I think that's the bane of our existence, working on surgical units.
Oh, yeah.
But one other thing I want to bring up about that consent is there's always that one question about whether you want to be resuscitated. This is different from doing an advance directive or something like that. This is for the procedure. I think a lot of people kind of take that a little bit too far. It's not necessarily that you are filling out an advance directive for what you want to do if you're unable to make decisions for yourself after an accident or something. This is for the purposes of this surgery. Sometimes patients get a little over-sedated, or maybe they react differently, and they just need a little help to wake back up. If somebody's a DNR, it might prevent them from getting some of those treatments. So we don't want to have them think too far down that path.
That and the other big thing I've struggled with, I'll say at nighttime, being a night nurse, someone will go down for surgery 12, 1 o'clock in the afternoon and not back sometimes until later into the night. And I say this not at any particular doctor I've ever worked with, but your care is only as good as their ability to program Epic at the hospitals I've worked at. And I say that because sometimes they'll write post-surgical orders that won't necessarily carry through and unhold on the MAR. So I'll have to page them or secure a chat and be like, hey, we need these orders released. You put them in, but they can't be released. And sometimes that could be a real deterrent in getting a patient comfortable when they come out of surgery and getting everything started for them. So I know that's a challenge I've faced multiple times in multiple settings of just getting that MAR to unhold to get them through their spot.
You brought up a very good point there. When I get confusion like that, when I was still working in the bedside, or as an educator now, somebody calls, I can't get hold of the doctor. And I say, go to the consent form and see who actually did the surgery, because you probably need to talk to the surgeon first, get those orders in. Even though you call the primary won't do anything. It's the surgeon who's going to do everything. And that's where the confusion is, because now you can't understand the name of the surgeon in the consent form. And another is, did they really sign the consent form and explain everything with the patient? That's another. So a lot of great points that we need to remember when obtaining that consent, but also understanding parameters set by physicians. Post-surgical patients, from their blood pressure, the diet, if they're diabetic, you mentioned, Laura, a while back, there's a lot of things that can be individualized for our patients. So very important that we know what our patients need after their surgery based on what they had.
I used to work with a surgeon, excellent surgeon, post-op infection rates 0. Everybody loved to work with him in the OR. He would come up to the room. He would actually pull up a chair and sit down and talk to the patient, and he would explain everything. Wow. And then he would leave the room, put the consent on the chart, and then write an order. Have nurse obtain consent. It took us years to break.
I about spit out my
habit. I mean, yes. What do you do in this situation? And we had to become really passive aggressive and send these patients down to the OR knowingly incomplete because they didn't have a signed consent. And eventually all of the OR nurses said, come on, you've got to do this properly. He was one of his sticklers for rules. That post-operatively, you didn't get anything but humidified oxygen. You did an advanced diet without him telling you to do this. But he would never get the darn consent form. It was the most frustrating thing. It really was.
Just to clarify, the order actually says obtain a consent?
Oh, yeah, he would write the order. This was back in the days when we had paper orders, and I'm going back a while. And he would write pre-operative orders, number 7 or whatever, have nurse to practice outside of their scope. And he got away with this for years. It just came to a head one day, and we all kind of down tools and said, look, you've got to see this through. You really do. Kind of moving on, for our nurses out there, one that might not be experienced, it might be new to the surgical arena, or they just need a little bit of refreshing. The AMSN core curriculum has a wonderful chapter on perioperative nursing care. We've got to bring it right back to basics. We've got to think about airway and breathing and circulation, depending on what kind of surgery the patient had. Now we know patients don't lay in the bed for 24 hours. They're home at 24 hours. So getting them up and ambulating per orders, of course, is really, really important. And those first 8 hours are just critical. They really are. We should be doing vitals per the physician order at the very least every 4 hours. I mean, much more frequently initially. Q1 1 hour is pretty acceptable for 4 hours when someone comes back to the floor, looking for wounds and drains and dressings and marking any dressings that may have some blood or serosanguinous fluid or whatever, marking that so we can have a baseline to see if there's any increase in bleeding, and then continue to monitor vital signs to make sure the patient is able to tolerate fluids. Once again, there'll be an order for that. I'm not sure if any of you have any experience with enhanced surgical recovery, where we have loaded these patients up with carbs pre-operatively and bowel sounds return much more quickly. And so that diminishes, of course, the elusive post-operative ileus that we were all taught in nursing school to listen for bowel sounds, to figure out what was going on there. So that's just a few kind of clinical tidbits to remember. Foley catheters, of course, at maximum 2 days post-operatively. If not, why is it still there? Most typically, in my facility, if a patient comes back to the floor early evening towards the wee hours of the morning, the first thing we do on that post-op day one is get that catheter out, because we do not want to be responsible for a catheter-associated urinary tract infection.
Caroline, I have to admit to a guilty confession here. When it talks to before and even afterwards, when we'll talk about just sips and chips of ice for patients.
Yes.
I'm guilty of doing this thing to kind of ease some patients. And I always asked them, I said, what is technically the definition of ice? And, I go back to my elementary school days, and ice is just the solid form of a liquid. It doesn't say what specific liquid. So I tend to throw an apple juice or cranberry juice in the freezer to have ice chips of cranberry juice or apple juice. So
I'll buy that one. I'll take it. I
had a doctor say
reasonable to me.
Right. Patients swear they won't say anything. So I'm like, hey, I'll make this a little bit easier for you. Especially, they've been NPO for a couple of days because there's an NG tube or a stomach problem and they just have ice chips.
Right.
And so they're so tickled to have ice chips of something besides water. So that's my little slide under the rule thing there. And I find one of the hardest things to do is really get patients up to ambulate, which, is like one of the most important things. And I just kind of try to remind them, the quicker you get up and moving, the quicker you get home. And God knows nobody likes to be in the hospital. So the hard part on night shift is we don't have as much help necessarily, especially if you have some of these bigger folks that are getting knee and hip replacements. Even towards the evening shift, you're still expected to get people up and ambulate, because we know getting ambulate and, like you said, getting those bowels moving, getting the blood recirculating is such an important part of their recovery. And the other day, actually, I had a patient that was in a car wreck, and it was the first time she had ever been in the hospital outside of having her children. She had never had surgeries and had quite a few fractures and breaks, and no one really talked to her about compartment syndrome, which I found really, really interesting, because I kept asking her about wiggling her toes and wiggling her fingers. And she just kind of kept looking at me like strange. And I said, yeah, compartment syndrome kind of explained the expansion of it and the fascia closing in. It's like, I'm glad someone told me about it. Like you said, you'd think the doctor would in the pre-op. When I get anyone out of surgery that's had a break, that and throwing a clot are my two big red lights I always think about dinging in my eyes all the time.
One thing that we're very big on my orthopedic floor, obviously, is getting our patients up. Now, sometimes we have to have some battles with these patients, especially because they're elderly and they weren't walking too good beforehand. It's not like we're looking for a miracle, you understand, but at the very least, we try on post-op day one in the morning to get our patients up and out of bed for breakfast. And they're usually fairly willing because it's the first big meal they've had in a few days, but all the evidence points to the fact that the bed is just not our friend anymore. And ambulation, even if it is just baby steps from the bed to the chair and then the chair to the bathroom maybe, is absolutely essential in providing a faster outcome without any complications like post-operative atelectasis or the risk of VTE development. We haven't mentioned sequential compression devices and sequential compression hose, absolutely essential, along with the pharmacologic adjunct as well by way of Lovenox sometimes added into the regimen. But, I always think about the commercial on TV body in motion stays in motion. Anyway, you get the drift here. This is what we have to impart to our patients. Laying in that bed, you are going to stiffen up. You are going to decompensate faster than you even realize. And it did blow me away when I went back into the clinical arena to see hip replacement patients going home, the very early morning of the post-op day one. Get them up, get them out, get them to rehab. It's so much different than it used to be because we've learned the hard way, unfortunately. The bed is not our friend. So a lot of encouragement, a lot of coaxing.
Education ahead of time, too. Let them know that this is what they can expect.
Absolutely.
We will be getting out of bed so many hours after your surgery.
We have a wonderful patient nurse navigator who does all of this pre-operatively with the patient, so they know exactly what to expect. And for those that say, no one told me this, Jess is like, oh, yes, I was there when we did this education. And of course, preparation before the procedure helps patients prepare and their families prepare mentally so that they can also be there as cheerleaders. Come on, it's time to get up, Mom. It's time to get up, Dad. We're going to walk down this hallway and everyone at the other end is going to be cheering you on. And we really, truly do.
Caroline, I remember your tips and I remember the INOs. That is so important too. I was making a checklist, checking off like what other things, and INO is like one of the biggest. It's not just the physicians really needing that, but I think for me, based on experience, communication between team members, like who's getting who and who's recording accurately. That's one. You also did mention about the SCDs. We had SCDs on, but is it connected to the machine? That's another.
It should be on the checklist.
Right? I laugh, but it is true, right? It is true. And then the medications, Caroline, you brought up a good point. Pharmacologic, the patient sometimes would refuse these medications. The heparin, they don't want to do it. Or the Lovenox, they don't want to do it. But educating them, the risks and complications after surgery. Not to threaten them or scare them, they're going to have a clot or so, but understanding that there are complications that may happen. Did he ever use their spirometer? It's been there at the bedside. Yeah, when you mentioned about the atelectasis, I was like, yeah, you're right, because are they using their spirometer? Did somebody even taught them how to use it?
It has to come out of the bag. You have to connect the mouthpiece. It's correct.
There's a goal that we need to reach,
That's right. Yes.
Yep.
Yes.
So much to talk about.
Majority of physicians, if somebody even starts slightly spiking a temp, will say, let them use the incentive spirometer first.
It is a wonderful little gadget with no batteries required,
Yeah,
it has to come out of that packet.
And they have to know how to use it appropriately too. They're not blowing there.
Yes, of course.
Oh my gosh. Well, we have talked about some wonderful things here, but believe it or not, we are just about out of time. So before we go, let's quickly summarize what we've learned. Number 1, to be sure to administer your antibiotics at the right time prior to surgery. Read your pre-op instructions carefully so you're doing things as they're supposed to be done. Make sure that your consent forms are signed. All you are doing is witnessing the consent. Hold your doctors accountable for filling out the consents with their patients so they can answer all of their questions. That's not necessarily our job. Make sure that the patients are fully undressed, including piercings, glasses, dentures. It's very difficult to undress these patients after they're sedated, and we also don't want these items being lost. So if they go down to your pre-operative area with any of these items, be sure you communicate that to the nurse that's receiving them so they can be responsible for taking them off. Be prepared when the patient returns from surgery. Fresh sheets and a nice clean bed, a warm room is going to go a long way. Remember that recovery begins with our patients being comfortable. Do your best to be at the bedside when your patient comes back to you. They are looking for your smiling, warm, caring face. Focus on what the patient needs at the time you receive them. Every patient has unique needs. You can even have that conversation ahead of time. Like, what would you want when you come back from surgery? What can I have ready for you? If questions or uncertainty arrives once the patient returns, especially late at night, look at the consent form to find out who the surgeon was and contact them rather than the primary physician. Be sure to get the patient up and ambulating per the physician orders. Always educate them and their families ahead of time regarding the plan for getting them out of bed and ambulating post-op, just to avoid any miscommunications. Also regarding the medications they'll be asked to take and the importance of those medications. So we want to be sure that we're educating the patients why they're getting those medications. Don't forget to check I&Os and always try to communicate effectively between team members. Your checklists are there. They are going to be your best friends. So be sure that you're taking advantage of them. All right, everyone. Thanks for joining us. We'll see you next time. We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org.
I'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurgMoments to your posts. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Caroline.
Laura.
Neil.
And this is Meritus. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that makes a huge difference.